This is Dr. Craig, and welcome to Top 10 Radiology. So, for hepatocellular carcinoma, let's briefly go over the staging, nodal, and metastatic disease. So, like many other cancers, HCC, it's important to report on size, with 2 centimeters and 5 centimeters being important cutoffs to distinguish between certain stages. HCC has been known to produce satellite nodules, so you want to count those. I've seen satellite nodules, like a group of satellite nodules after vascular invasion. So that kind of brings up the next point of look for vascular invasion. This is where portal vein is going to be by far the most common. And you can see that actually on ultrasound. The good many of that would be showing an arterial waveform in a thrombosed portal vein with Doppler ultrasound. So that's showing that it actually is tumor thrombus and not bland thrombus. For end staging, we're looking at regional nodes, including the basically everywhere close to the liver. And then long Mets being the most common, followed by bone, and they're very close, as well as non-regional lymph nodes. So it's kind of nice, again, I think about the ease of the triple phase liver scan, that it scans the bottom of the lungs, and so it's important to look for nodal Mets there. So again, I write complications, including vascular invasion. And then some of the pearls with this disease is lung only and bone only. Metastatic patterns were common. So if you see it in the lung, then you might not be seeing it in the bone as much, despite the fact that they're the most common top 3 sites. And then bone mets were typically lytic with the soft tissue component.
All right, let's look at the first case of hepatocellular carcinoma. As you can see here, this is going to be a triple phase liver CT with, if we can look at the opacification of arteries and veins, we can tell what it is. And so in this case, the hepatic artery is opacified, as well as the portal vein, without necessarily opacification of the hepatic veins in this case. And so to me, this is going to be an adequate arterial phase study. What I'm looking at is this heterogeneous mass here that has apparent arterial enhancement, or at least arterial hyperenhancement relative to the background parenchyma. This can be easily shown as just doing a simple ROI on the lesion itself. And you'll see that this says 128 and this is 150. So it tells me that there's arterial phase enhancement. And then I'm going to look at portal vein, which is portal venous phase, which is this. And I can tell it is because there's hepatic veins and the portal veins are opacified. So what I do here is, again, you can window it kind of hard. Window it as you see fit to show that there is. On a general view, this is kind of hinting that there is washout, as you can compare this to this. But if you really window hard, the appropriate way that you see fit, then you'll see that there is absolutely washout on this lesion. We can confirm it by looking at background enhancement versus the washout appearance that we see here. And this is 125 and 104. So that's telling us that it does wash out. And then we'll do a quick view of the delayed, and on the delayed, you can see a pseudocapsule here too. So those are the 3 properties that you're looking for: is arterial phase enhancement or hyperenhancement relative to the background, and then washout either in portal venous phase or delayed phase. Some tumors take a little bit longer to get rid of the contrast from their leaky arteries, and so that's why it's important to review it on both delayed and portal venous phase, or even actually when you're evaluating for HCC on a patient with cirrhosis that doesn't have a known tumor. Even if there's not arterial enhancement, if you see washout on portal venous phase or delayed phase, then it's going to be worrisome for an HCC. That would put it, depending on the size, I could put it at LIRADS 4, I believe. So this has a pseudocapsule as shown here, another illustration of washout where it's 103 versus 91 there. And now we want to look for metastatic disease, or at least nodal disease, rather. That's kind of the first step. I have a really hard time with nodal disease, so I try to look at the liver hilum, and that's kind of where you're going to find them. If you notice here, I put a measurement on it already, which should be the first clue, but this just it's around nodularity. It looks like it's kind of bordering the liver, but doesn't look similar to the liver parenchyma. We could tell this if we want to. If you really are unsure, you can look at it on the arterial phase and portal venous phase and make sure that it doesn't look like the liver. But in this case, it's nice and round. It measures 13 millimeters, so that's highly suspicious as a portal node. Here is the other one that is typically a little bit enlarged, but in this case, it looks a little bit more suspicious than it normally does. And then we have another one here following. This is more portal caval right here. And then looking for metastatic disease, again, the lung bases are included in these triple phase studies even when we're screening, so it's important to review for any type of metastatic disease. I don't see any nodules on a quick run through here. That caught my eye, but it's not anything. And then looking at bones, again, coronal and sagittary best friend, nice view, straight view of these ribs, nice straight view of these ribs. And we have a nice little bone island there. If I put a ROI on it, I'm sure it's over 1,000. This is kind of indeterminate, but I wouldn't even mention it just because we see them a lot. I mean, the same with that. Another bone island, it appears. Vertebrae, again, are more common for metastatic sites, I think just based on surface area alone. Nice straight view of the ribs, so nothing's there. And then the last rundown would be looking for any type of distal nodes that are basically not in the right upper quadrant. You think about retroperitoneal, maybe mesenteric, but nothing is coming through on this quick view, although it's kind of challenging with a person with very limited amount of mesenteric fat. Okay, let's review another HCC case. Again, this is a triple phase liver. If you look here at the liver, on our standard windows, it's actually not terribly impressive. It's very heterogeneous and obviously cirrhotic. I mean, there's something going on here and there, but let's put it on. If we put it on our liver windows, you start to see a lot more exaggeration of the arterial enhancement that you can see here. And so to me, this is a giant tumor. And so looking at this again to evaluate for vascular invasion, or actually even just to see if this is a good study or not, you can see that the hepatic artery is opacified, but the portal vein isn't. And so as a result, that's telling me that this is kind of too early. But although we have very good reason to believe that there's something abnormal here. So if we go to the portal venous phase, that area washed out, that's going to be this area. And what you can notice if you really window down is if we look for the portal vein itself, we have the SMV, splenic vein, portal confluence, and you see that there's a filling defect here. If you follow it through, it's going to actually connect with that kind of that area of washout. And so to me, this is insanely suspicious for portal vein thrombus. Believe it or not, they did an ultrasound on it. Let me pull that up here. And it was read as just bland thrombus. Although to me, it's a little bit suspicious. I would have definitely questioned what they were looking at here. In the main portal vein specifically, this isn't really getting good venous waveforms or arterial waveforms, but this is essentially how they would show it with this being more vascular. Maybe if we investigated that area, it would be a little bit better. Again, if we want to do the complete studying exam, wow, this person has a very large heart. I'd be looking at the lung bases for anything abnormal here. I don't see any nodules. There's an effusion, but that effusion could be related to the fact he's got ascites, so it could be hepatic in nature. And then looking for lymphadenopathy here, again, you just have to look at the common sites, and common sites being common, you just have to kind of call it as it is. Here's that portal caval lymph node that's kind of elongated. It's not as round, but this one certainly is abnormal in the same position that they had here. And given the extensive tumor, I would imagine that that we're having local nodal disease. And if you look here as well, you're going to see a lot of satellite nodules. I found in practice that if there's portal venous invasion, that satellite nodules are going to be very very common, just because I think it's a good route for the disease to spread.